Good morning. My name is Annie Amin. I'm a pediatric anesthesiologist at Cincinnati Children's Hospital. I'm excited to be with you all in San Antonio to talk about perspectives on pediatric surgical emergencies in daily practice. So this is meant to be interactive. There will be some audience polling, so please take a moment to scan the QR code so that you can participate. All right, you might be wondering why Noah Weil and what he has to do with common pediatric surgical emergencies. But if you've never watched The Pit on HBO, I think it is fairly realistic for a medical drama, except the scene where the anesthesiologist could not intubate and the ER physician had to rescue the airway. So each episode is 1 hour of an ER shift. So today, I'm going to take you on an hour-by-hour day through the operating room and guide you through how to review, optimize, and triage common pediatric surgical emergencies. So our learning objectives today include how to assess and triage common pediatric surgical emergencies, discuss strategies for preoperative optimization, apply evidence-based principles of anesthetic management, identify optimal timing for surgical intervention, and examine the role of point-of-care ultrasound in the evaluation of surgical emergencies. So let's review some common pediatric surgical emergencies. We have abdominal emergencies that include incarcerated hernia, pyloric stenosis, intussusception, malrotation with volvulus, appendicitis, neonatal emergencies, which I think deserve a lecture dedicated to them, so we're not going to talk about them today, but for completion, it includes congenital diaphragmatic hernia, tracheoesophageal fistula, omphalocele, and gastroschisis. ENT emergencies, including tonsillar hemorrhage, epiglottitis, foreign bodies, orthopedic emergencies, including open fracture and pulseless fracture, neurosurgical emergencies, including VP shunt malfunctions and burr holes, urologic and gynecologic emergencies, which are mainly just testicular and ovarian torsions, ophthalmologic emergencies, including open globe, and dermatologic emergencies. Just kidding. We know those do not exist. So let's meet our cast. Today, all of you are making a special guest appearance as our pediatric anesthesiologists. We have our ENT surgeon, our urologist, our neurosurgeon, our pediatric surgeon, our orthopedic surgeon, and our dermatologist, who is just here to remind us we could have all had a 9 to 5 with no call or no weekends. So it's 6 a.m. This is your add-on board. The cases in no particular order include an 18-month-old with an esophageal foreign body, a 12-year-old female with appendicitis for a laparoscopic appendectomy, a 5-week-old male, 3.5 kilos with pyloric stenosis scheduled for laparoscopic pyloromyotomy, and a 6-year-old male with a supracondylar fracture scheduled for a percutaneous pinning. So you are tasked with determining case order, evaluating OR readiness, and if the patients require any further workup, you are also tasked with managing the surgeon's expectations with limited OR availability. As you move through this lecture, I hope you'll gain an understanding of these common surgical cases, indications and timings for proceeding, and develop an understanding for how to triage unexpected emergencies. So our first question, what other information would you like in order to determine case order? And this is just an open-ended question. Great, so vital signs, all our patients are hemodynamically stable. All of our patients are, our esophageal foreign body has been asymptomatic. He was admitted yesterday evening. The lab values for our 5-week-old include a bicarbonate of 28, a chloride of 100, and a potassium of 3.8. The orthopedic supracondylar fracture has intact neurovascular status. The fracture does have a pulse and is the 5-week-old medically optimized, and they were admitted yesterday morning. They've been on fluids overnight. Great. So what order would you do the cases? All right, we're going to move on. So I'm going to do the pyloromyotomy first, even though that was not the majority question. So I like to do our youngest children first, and especially when everybody's bright-eyed and the patient is ready and has been here for about 24 hours. So let's first review on how to proceed. A little bit of history on pyloric stenosis. So it is the most common acquired pediatric condition with an incidence of about 2 per 100,000 live births. It is most common in firstborn males between the ages of 2 and 12 weeks, and it presents with non-bilious projectile emesis, though the presence of bilious emesis does not exclude the diagnosis. The pylorus is thickened, resulting in narrowing, so the physiology is that of a gastric outlet obstruction. The diagnosis is confirmed with both a history and physical and radiologic imaging, and point-of-care ultrasound has been described to be used by both ER physicians and surgeons to make the diagnosis. It is classically a donut sign because of the thickened pylorus. These patients typically present dehydrated with a hyperkalemic metabolic alkalosis, though a late-stage presentation can present as metabolic acidosis. There's typically a palpable olive sign, though patients presenting early may or may not have this finding. It is contrary to what surgeons say. It is not a surgical emergency. It is a medical emergency, so we want to be sure that our patients are optimized prior to coming to the operating room. So it is our role as anesthesiologists to make sure the patient is both medically ready for the operating room and safe for general anesthesia. So patients with pyloric stenosis are considered optimized when they've had a correction of both their electrolytes and adequate volume resuscitation with a urine output of 1.2 mLs per kilo per hour. Proceeding without optimization can result in cardiovascular collapse. And the goal of correcting that alkalosis prior to coming to the operating room is to minimize the risk of pre- and post-operative apnea in these babies. So we know that prolonged periods of metabolic alkalosis in neonates suppress the minute ventilation, so there's a compensatory increase in PCO2 to increase the pH. In addition, there has been literature to suggest that there is both an elevated emergence time and a length of stay of surgery with an uncorrected preoperative CM bicarbonate. So this study looked at the specific values and found that a value greater than equal to 24 was linearly associated with a prolonged emergence time. And then they looked at binary variable of a greater than 30 or less than 30 and found that greater than 30 had a 5.4 minute increase in emergence time. And so it appears that 30 is the magic number as the risk of both prolonged emergence and postoperative apnea is minimized. How would you induce this child? Great, so most of you would have chosen a classical rapid sequence induction with about slightly less picking a modified rapid sequence. So the induction technique for pyloric stenosis, as you know, is a balance of reducing the aspiration risk in addition to minimizing the apnea time. So we know that neonates, infants, and smaller children have a decreased apnea tolerance. They have a greater closing capacity, which leads to airway collapse after induction, and they have a higher oxygen consumption. So there's no definitive consensus, and the very, very old literature suggests an awake intubation, which has fallen out of favor as we no longer like to subject neonates and infants to painful procedures without anesthesia or analgesia. The literature also suggests a classical rapid sequence induction and intubation, so that's recommended to avoid aspiration of gastric contents. However, we know that that is a stressful experience both for us and the neonates we're anesthetizing. Infants have a reduced tolerance of having apnea time during the paralytic starting to work. So this approach is associated with a higher degree of hypoxemia, bradycardia, and difficult airway as cricoid pressure can make the visualization of the glottis more difficult. So next is inhalational induction, which if you trained when I did, it was unheard of to do an inhalational induction in a pyloric stenosis. However, there is ongoing literature to suggest that this may be a safe approach. So there was a study out of the UK that reviewed 269 infants. 94% of them had an inhalational induction. The anesthesiologist suctioned the stomach prior. Paralytic was administered prior. And there were no episodes of severe hypoxemia or any aspiration. Next is a modified rapid sequence intubation. The theory behind this is that low ventilating pressures allow for to preserve oxygenation with decreased risk of gastric insufflation. This is associated with the less severe incidence of severe hypoxemia and bradycardia, but it does require adequate patient selection similar to an inhalational anesthetic. So luckily, with the use of gastric ultrasound, we no longer have to make a blind decision. This is a tool that has been used more frequently in pediatrics. It's a point of care tool to assess gastric volume. It's non-invasive, it enhances our clinical decision making, and it's typically very well tolerated in these neonates. So this study by Gagey followed 34 infants with pyloric stenosis. He used a high frequency linear probe to measure both the longitudinal and the AP diameter of the stomach from serosa to serosa. He then compared that with the aspirated gastric contents from a gastric tube and found a significant correlation in the right lateral decubitus position. Subsequently, they did a second exam after aspiration of contents. If the stomach was empty, the team proceeded with a non-rapid sequence inhalational induction. If it was not empty, then they had a classical RSI. There were no incidences of any aspiration events during this. The stomach was considered empty if there's less than 1.5 mLs per kilo of fluid and absence of hyperechoic material. They used both of these equations to calculate both the antral area and the volume. With the use of gastric ultrasound, change your induction choice. So majority of you said yes. So I'll present a case to you where we had a 4-week-old male with pyloric stenosis. He presented for pyloromyotomy. He's 2.76 kilos, and he'd had projectile emesis for 3 days. So we scanned the patient prior to suctioning. This is his stomach. You can see the live liver edge. Sorry, I don't see if I can get my pointer to work. You can see the liver here, and you can see the stomach, which is full of both gastric fluid and hyperechoic material. The team suctioned the baby in all 4 quadrants and then repeated the ultrasound. You can see that the stomach there's the liver edge, and it appears empty and flattened. So the team elected to do a modified rapid sequence induction. They did gentle bag mask ventilation, and they combined both an inhaled and IV induction. There was no desaturation, no bradycardia. They stated otherwise the plan would have been a conventional rapid sequence and that would have put the child at risk for severe hypoxemia. So this is a great example of how POCUS can help guide our decision making to more safely take care of our pediatric patients. What is your preferred airway method to intubate a neonate? So fairly split between direct laryngoscopy and video laryngoscopy, with about 14%, which is my choice, depends who's intubating. So now that we feel fairly comfortable with our choice of induction, let's discuss airway management and review what we know from the literature for neonatal airways. So a large cohort study out of Europe, the Nectarine study, which stands for Neonate Children Audit of Anesthesia Practice in Europe, looked at 4,700 tracheal intubations. The primary endpoint was incidence of difficult intubation and related complications. The secondary were risk factors for severe hypoxemia, which they defined as less than 90% for 60 seconds, attributed to difficult airway management, which they defined as greater than 2 attempts. They also looked at the 30 and 90-day outcomes. They found the incidence of difficult airway in children with a post-conceptual age of less than 60%, resulting in severe hypoxemia. Those children were at the greatest risk. In addition, they found patients with pyloric stenosis were at an even greater risk of a difficult airway and complications. There was no increase in 30 and 90-day morbidity and mortality. Now, disclaimer, no one looked at the anesthesiologists that were anesthetizing these infants, So overall, the literature confirms what we feel, and that anesthetizing neonates is high risk. So the European Society of Anesthesiology and British Journal of Anesthesia put out joint guidelines for neonates and infants. They recommended that a history and physical would be used to predict a difficult airway to ensure adequate sedation and anesthesia. Depth of anesthesia, as light anesthesia can be associated with laryngospasm and bronchospasm and other complications. To administer neuromuscular blockade to facilitate intubation when spontaneous ventilation is not necessary, and to use apneic oxygenation, such as a nasal cannula or a high-flow nasal cannula, and video laryngoscope as first line, as there's been lots of data to suggest that increases success rate on the first attempt. To supplement that with angulated stylet if needed, a supraglottic airway for rescue, to limit attempts, and to verify with end-tidal CO2 and clinical assessment. So you've performed a gastric ultrasound, you feel comfortable with the modified rapid sequence, you have your preferred airway equipment, which is a Miller 1 blade, but the anesthesia board runner calls you and says, I really think this is a great learning opportunity for our brand new anesthesia resident. So he waltzes in, he's like, I've never intubated a baby before, but I'm super excited. But fret not, you have a solution, your CMAC Miller 1 blade. The advantages of this is that you can help trainees troubleshoot the airway. You can visualize the confirmation that the endotracheal tube is in the right place, which allows for faster diagnosis if there's absence of end-tidal CO2, and that rules out an esophageal intubation. So you teach the resident, you allow him to do the first attempt at direct laryngoscopy, slightly sloppy with the tongue hanging over the right side, but he's able to successfully intubate on the first attempt. The baby does not have any desaturation and is safely intubated. So who has the largest change in their heart rate while anesthetizing a neonate? So most of you say both. I agree. But hopefully with everything that you've learned, the neonate will have less changes. So congratulations, you finished your first case. You're now ready to send for the laparoscopic appendectomy. So as a review, this is the most common indication for abdominal surgery in children. It presents with abdominal pain, fever, nausea, loss of appetite. The goal of getting to the operating room expeditiously is to prevent the formation of an intra-abdominal abscess, which reduces morbidity. Complicated appendicitis is more common in female children under 7 years of age, and the timing has shifted from emergent to urgent. So the questions still remain: what is the optimal timing for the operating room, and should we be optimizing complicated appendicitis prior to coming to the operating room? So at your institution, how soon should an uncomplicated appendectomy present to the operating room? The majority say within about 24 hours, and nobody within 2 hours. So time to appendectomy, this is still heavily debated in the literature, but there is literature to suggest an uncomplicated appendicitis can be scheduled as an urgent and not emergent procedure. If patients present to the operating room and are given IV antibiotics and are in the OR within 24 hours, the risk of associated complications is very low. It's also important to note that nearly all intra-abdominal abscess formation occurs in children with a history of an appendiceal perforation, whether that's at presentation or discovered in the operating room. There's also data to suggest that we should not be rushing children with complicated appendicitis to the operating room, and that they would benefit from both preoperative antibiotics and resuscitation, which will decrease their risk of postoperative complications, including their chance of infection. So at our institution, our guidelines are typically an uncomplicated APIs in the OR within 8 hours. That can be longer depending on surgeon availability and acuity of other cases. A complicated appendicitis with suspected perforation is 4 hours, and sooner if there's signs of sepsis. So in general, thankfully, we've moved away from doing APIs in the middle of the night. And what is your preferred induction choice for acute appendicitis presenting for appendectomy? So very few of you would do it, classical rapid sequence, and then split between modified and depends on symptoms and duration, and about less than only one is doing gastric ultrasound. So anesthesia for acute appendicitis. So we know that the risk factors for delayed gastric emptying, including pain, nausea, ileus, and anxiety. However, there is literature to suggest that in adults, a minority of adults with uncomplicated appendicitis and appropriate NPO have high-risk gastric contents. Now, in pediatrics, to do a gastric ultrasound in a child in pain is a lot more difficult, so the literature is still inconclusive on pediatrics. If the patient tolerates, gastric ultrasound is a great tool to be used for an evidence-based approach. However, I am very similar to all of you that I base my decisions based on clinical assessment. So if the child presents uncomplicated with no emesis, I proceed with a modified. If there's high suspicion of perforation, uncontrolled fevers, or symptoms for extended period of time, or confirmed imaging of perforation, I proceed with a rapid sequence. In addition to the actual operation, there's literature to say that uncomplicated appendicitis can be safely discharged on the day of surgery. That helps reduce hospital length of stays and costs, and families much prefer to recover at home. So in addition, to optimize patients that leave on the same day, you want to consider non-opioid adjuvants, including ketorolac, consider regional anesthesia, transverse abdominal plane blocks, or rectus sheath blocks, and and our surgeons are increasingly doing single incision laparoscopic appendectomies, but the benefit of that is really primarily cosmetic. So you finished 2 cases, you're ready to sit down for your coffee, you got your crossword puzzle out, and you feel like you've already worked pretty hard today. So your board runner calls you one more time and says, "Not so fast, drop your coffee, there's an emergency." So we have an emergency bleeding tonsil. It's a 5-year-old male. He status post-adenotonsillectomy for sleep disordered breathing 7 days ago. He presents to the emergency room after an episode of hematemesis. There's an active ooze visualized in the posterior tonsillar fossa, but he's not cooperative with your attempt to cauterize with silver nitrate. He's pale, he's lethargic. The otolaryngologist calls you to book an emergent operating room. You state all operatings are full, but you'll hold a case and bring the patient as soon as possible to the operating room with the goal of within 30 minutes. You suggest inhaled tranexamic acid until an operating room becomes available. So the emergency room calls you and says they're having great difficulty placing a peripheral IV and asks if you can do an inhalational induction. So almost nobody would agree that to do an inhalational induction. Most people would have some sort of solution, including having the ER place it and or you placing it awake in the OR. So let's review the bleeding tonsil. So primary bleeding typically occurs less than 24 hours. This is from a failure of primary hemostasis. Secondary bleeding is typically occurring between 5 and 12 days. That's due to disruption of the healing clot. The risk factors for bleeding tonsil include surgical technique, age greater than 5 years, chronic tonsillitis, and preoperative aspirin or NSAID use. The complications include hematemesis, anemia, hypovolemia, or death. The preoperative assessment is very important as the amount of blood loss is very difficult to quantify in these children as it's mostly in the stomach. The urgency of surgery should be evaluated. So things that point you to an emergent surgery include evidence of an arterial bleed, an uncontrolled bleed. Other things where you have a little bit more time to bring the patient to the operating room include a bleed that has happened at home and perhaps has gotten to the ER and has stopped. They still require surgery, but it is less of a time crunch. You want to immediately obtain IV access and begin resuscitation. And then temporizing measures include silver nitrate cautery, pressure if the child tolerates, and then there's evidence that inhaled tranexamic acid can either mitigate the need to come to the OR or significantly reduce it. So the question of how to induce a bleeding tonsil, so to ventilate or not to ventilate. So there is good data out there. There was a retrospective chart review of 475 patients. 84% of them had a true RSI, 5.5% had a modified, and 3.2% had a mask induction. Again, the main complication was hypoxemia, followed by bradycardia, hypotension, and difficult intubation. And these were in children that were not previously difficult to intubate during their initial surgery. And 58% of the hypoxemia was on emergent, so related to things like laryngospasm and bronchospasm. Another study compared both RSI and modified. Modified had a lower incidence of severe hypoxemia, better direct laryngoscopic views, and less hypertension. And importantly, there was no significant perioperative pulmonary morbidity in either group. It is my opinion that patients with very brisk bleeding should have their airway secured as quickly as possible with a classical rapid sequence intubation. So my anesthesia setup for these cases, I typically ask the circulating RN to have 2 suction canisters available in the event that there's any rapid bleeding. I prefer direct laryngoscopy as blood and secretions can obscure your view with video laryngoscope. I always paralyze, whether that's with succinylcholine or rocuronium, and I always ask for my ENT surgeon in the room in case of any difficulty with the airway. So it's 11 a.m. Our esophageal foreign body has been patiently waiting. So the timing of assessment of bringing these patients to the OR can be split into 3 different categories, and that's dependent on the patient size, type of object, location, time since ingestion, and their clinical status. So emergent is less than 2 hours, regardless of NPO. Urgent is less than 24 hours with adequate NPO, and elective is greater than 24 hours with usual NPO guidelines. So these patients can present with drooling, emesis, dysphagia, cough, inability to control their secretions, feeding refusal, stridor, fussiness, abdominal chest pain, and respiratory distress. Over 100,000 children under the age of 6 per year swallow foreign bodies, so it is very common. Retention can lead to mucosal injury, perforation, stricture, obstruction, and laryngeal edema. Large objects greater than 6 millimeters are less likely to pass. Urgent emergent removal are for button batteries, multiple magnets, sharper absorptive objects, or signs symptoms of airway compromise. So esophageal foreign body removal should be done either with a rigid esophagoscopy by ENT or flexible by GI. NASHPGAN, which is the GI Society, recommends an endotracheal tube to avoid dislodgement of the foreign body into the airway. However, no anesthesiologists were consulted during this, so we have done our own investigation. So there's data to suggest that a natural airway can be an alternative for coin removal for patients that are appropriately NPO without history of reactive airway disease, and the procedure is expected to be short and uncomplicated. So 326 patients, of which 77% had a MAC. Only 3 patients required conversion to general anesthesia. That was due to underlying risk factors, including reactive airway disease and active URI or difficult airway anatomy. And no patients had aspiration or dislodgement of foreign body into airway. When I do these cases, I tell whoever is intubating, grab the McGills. If we see the coin, we keep it. And then the surgeon can just do a very quick esophagoscopy and we're done. Button batteries deserve their own recognition. So on X-ray, these are typically with a double halo sign. That is how you differentiate them from an esophageal coin. Injury begins as soon as 15 minutes for button batteries. It's a caustic alkaline injury. Generation of hydroxide radicals and mucosa raise the pH. Lithium batteries, due to their size, they're thin, they make larger content with mucosa, and they have increased voltage delivery, are especially dangerous. The sequelae of button batteries are unfortunately very significant, including tracheoesophageal fistulas, esophageal perforations or strictures, recurrent laryngeal nerve injury, mediastinitis, and aortoenteric fistulas, which are usually lethal. So the guideline for removal states that if any button battery is in the esophagus, it should be removed immediately within 2 hours, regardless of fasting status. That is for symptomatic or asymptomatic patients. If the child is clinically unstable, you need to rule out a vascular injury, so you need to do imaging to exclude aortic injury. If that is present, you need to involve a multidisciplinary team, including general and cardiac surgery. Neutralization has been suggested, so if the ingestion is less than 12 hours and it's witnessed, and the child is greater than 1 year of age, immediately give 10 mLs of honey every 10 minutes up to 6 times. And that is to prevent significant mucosal injury. So button batteries in the stomach or beyond can be urgently removed, but not emergently removed. It is indicated to remove them if the child is symptomatic, if they're large, greater than 20 millimeters, if they're less than 5 years of age, or retained greater than 48 hours. Otherwise, you can follow and repeat with serial imaging to make sure that the battery has passed. Removal should be immediately done under endoscopic removal under general anesthesia, rigid or flexible. You do not delay for NPO status because the risk of catastrophic injury outweighs aspiration risk. You want to inspect the mucosa carefully after removal, look for burns, necrosis, perforation, and then admit if significant mucosal injury, keep the child NPO with IV antibiotics, and do an esophagram prior to feeds. And it's important to monitor for delayed complications, including fistula, stricture, bleeding, with multidisciplinary follow-up with ENT, GI, and surgery. Other foreign bodies that are notable include magnets, as these are increasingly present in children's toys. So if they swallow more than one magnet, that puts them at risk of an enteroenteric fistula formation between magnets and adjacent loops, with associated perforation, peritonitis, bowel ischemia, and necrosis. If it is beyond the stomach, that's a consult for general surgery, as they may need to be laparoscopically removed. Sharp objects often pass uneventfully, but the main risk is perforation, with the ileocecal region being the most common site. If the child is asymptomatic, distal to the ligament of Treitz, you can follow clinically with serial imaging. And then there's super absorbent objects such as water balls that absorb up to 100 times their weight in water. So that is an emergent removal to avoid obstruction, and I think a lot of them have come with warnings. And there's food impaction, which I saved you a picture of and is in general my absolute least favorite case in pediatric anesthesia. However, it is emergent if the patient is not tolerating secretions, if it's urgent, and it is less emergent if they are tolerating their secretions. And this should be done by GI, as there's a high suspicion of eosinophilic esophagitis. It is finally time for our supracondylar fracture. He's been waiting very patiently, and he's ready to come to the OR. But not so fast. You have another emergency. You have a 12-year-old with sudden onset testicular pain with nausea and emesis. On physical exam, there's an enlarged hemiscrotum with a high riding, tender swollen testicle. The cremasteric reflex is absent, and he's otherwise healthy and ate breakfast at 7:30 a.m. Urology would like to proceed as soon as possible. So testicular torsion, if the orchiopexy is done within 4 hours, this is complete testicular viability. However, germ and Leydig cell function can still be preserved after 12 hours. Beyond 24 hours, it's complete testicular atrophy despite detorsion. You do not want to delay for ultrasound confirmation. And in children, this is typically due to the bell clapper deformity, which affects both testes, and this is where there's an absent gubernaculum, and the testes does not connect to the tunica vaginalis, thus putting it at risk for torsion. So there should also be a contralateral orchiopexy done at the same time. So our orthopedic surgeons have been super patient, but they are getting quite impatient, so they've come to talk to you.
There is a fracture. I need to fix it.
Okay, tell me more.
There is a fracture. I need to fix it. There is a fracture. I need to fix it.
Can you tell me more?
The fracture is very displaced. I need to fix it.
Okay. Let's start from the basics. Where is the fracture?
The fracture is in the emergency department. I need to fix it.
That's not what I meant. Who does the fracture belong to?
The fracture belongs to a bone. The bone is a femur.
And who does the femur belong to?
Ah. The femur belongs to a 97-year-old lady from a nursing home.
Okay. Anything else you can tell me?
She is fasted. That is good.
Any comorbidities?
She is otherwise well. Except for
Except for what?
her temperature is 29 degrees
Right.
and her pH is 6.8.
Really?
And she has a condition I have not seen before.
Which condition is that?
A systole.
A systole.
A systole.
Right. And you want me to anesthetize her?
There is a fracture. I need to fix it.
Why?
I apologize if any of you are married or related to an orthopedic surgeon. So for supracondylar fractures, there's 4 types. The first type is non-displaced. You can cast for 3 weeks and follow up. Second type has an intact posterior hinge. It's typically treated with a closed reduction and pinning versus a closed reduction and casting. Type 3 and 4 are treated the same. It's dependent on the degree of displacement. A closed reduction and pinning versus open reduction if closed reduction is unsuccessful. So reasons for urgent surgical intervention include open fractures, abnormal neurovascular exams, skin puckering, floating elbow, which is a supracondylar fracture in addition to a proximal radial fracture, severe swelling, impending compartment syndrome, or a pink pulseless hand. So this is lack of a radial pulse, but the hand remains pink due to collateral flow. Those are typically emergent as we need to the vascular status has to be reestablished. So it is treated by a closed reduction followed by pinning. If the hand is still not is well perfused, then you pin in the 40 to 60 degrees and the child is admitted to the ICU for serial checks. If perfusion is still not restored, that's an immediate arterial exploration. So anesthetic management of a supracondylar fracture is typically, these are typically healthy children and you can wait for adequate NPO status. So supraglottic airway is a reasonable anesthetic. However, the surgeon, this might be an old fracture or very difficult to reduce fracture, so they might request paralytics. It's also not uncommon that surgeons request that these patients are done in the prone position. That's typically if the closed reduction has failed in the past. Perhaps they tried to reduce it in the ER and they did not have any luck. So then you need to do an endotracheal tube and paralytic. The pain is improved after reduction. So I typically tell, whoever I'm working with, judicious use of opioids. And then disposition is typically for admission for monitoring of neurovascular status and compartment syndrome. So I recognize this is a very busy slide, but I did want to share with you our guidelines at Cincinnati Children's Hospital. I'm happy to share them with you outside of this lecture. So we have 5 categories. A is being less than 30 minutes. You can see that it's not a very long list. B is less than 2 hours. C is less than 4 hours. 8 is less than 8 hours. And E is a very elective case that is 24 hours. So cases that are less than 30 minutes, those are acute life-threatening, so loss of life or limb. So malrotation with volvulus, acute bleeding trauma, airway emergencies, and neurosurgical with imminent herniation. These are just guidelines, so clinical judgment is, of course, important in determining acuity of cases. And then less than 2 hours are emergent but not life-threatening, so things like acute shunt malfunction, compartment syndrome, incarcerated hernia, open globe, bowel perforation, torsion, or ischemic limbs. So now as a review of what we learned about rapid sequence induction and intubation in children, it's important to note that there's been no mortality from pulmonary aspiration that has been reported in large center studies, and the risk of pulmonary aspiration in pediatrics remains low It is higher in emergency surgery, but it can also be unpredictable. It's most common in ASA 1s and 2s with appropriate NPO. Rapid sequence inductions are associated with a high degree of cardiorespiratory complications, including severe hypoxemia, bradycardia, and incidence of difficult intubation. Neonates, infants, and smaller children have a reduced apnea tolerance, so their closing capacity is greater, leads to increased airway collapse after induction, and they have a higher oxygen consumption. It still remains a tool for our highest risk patients. Modified RSI with gentle mask ventilation is considered safe with incidence of severe complications. And regardless of your choice for induction or intubation, you always want to optimize your first attempt. And another review on POCUS. So gastric POCUS is a useful, reliable, in clinical settings. It can help optimize induction in emergency surgery and anesthesia. It can also help emergency room physicians and surgeons diagnose foreign bodies and pyloric stenosis, and it should only be used as an adjunct to clinical judgment. Are you more likely to use POCUS to guide your clinical decision making? Great. Now there's time for questions. Happy to answer any if you have some. Yeah, it's an interesting question because we only triage, pediatric emergencies. I think younger children at risk, I guess I should ask, how acute of cases are you doing? Are you doing all sorts of pediatric cases, or are you a referral center and you send patients out? And say that again. Oh, tonsillar bleeds, yeah. So I think tonsillar bleeds are a thing that, if there is a significant bleed, then it kind of trumps other emergencies. Esophageal foreign bodies, we don't treat those necessarily as an emergency. So within about 24 hours, if the patient is asymptomatic, so younger children are less tolerant of foreign bodies, but older children with foreign bodies that, it's unlikely large foreign bodies are going to move. And then if there is a chance that, it could pass, then we'd consider serial imaging before bringing them to the operating room. So it really depends on patient symptoms for foreign bodies and the age of the child. So, we proceed more quickly with a young child with a coin because it can cause some airway compromise. But otherwise, asymptomatic patient with a foreign body that is not high risk, such as, a pointy object or a magnet of that sort, we treat fairly electively. And appendicitis, if it's uncomplicated, I think within 24 hours is completely reasonable. What we typically do is our appendix, we have a couple general surgeons on call, and the appendix, the appendectomy is typically the first case of the day, regardless of when they come in. So say they came in yesterday evening and, and it's not at a time that the surgeon wants to come in and do it, then it's placed as a first case start. We also reserve some 6 a.m. times for APPEs at some of our other satellite locations. Pyloric stenosis always. We decompress. Typically, I use a larger suction catheter versus an NG tube because I find it to be more successful. Bleeding tonsils, not necessarily. Most children are not very tolerant. They're a little bit older, are not very tolerant of gastric decompression prior to proceeding. So for pyloric stenosis, depending on, I think there's all sorts of techniques that people do. There's a lot of people will pre-oxygenate prior to suctioning because these children are at risk for apnea. Babies are weird. You do anything to them and they stop breathing. So we will typically pre-oxygenate and plus or minus giving atropine prior to suctioning to prevent any bradycardia. Proceed with suctioning all 4 quadrants, and then depending if you do gastric ultrasound or not, utilize that as a tool to determine your induction choice.
What about after induction in nappies? I typically put suction of the stomach after induction in nappies, regardless of induction technique, but I'm just asking what your.
I don't feel strongly really either way, but I'd say the majority of us would suction the stomach prior to waking up. And then I always will, if a child is, if I'm considering them for any form of rapid sequence, they're getting woken up. So they're not going to be a deep extubation. All right, I think that's it. You guys get some time back. So.